Welcome back to Falcon Physician Reviews for discussion of adrenal medullary tumors. A discussion of pheochromocytoma. Just by way of background, pheochromocytoma, although all medical students would love to make the diagnosis, it's a very uncommonly encountered diagnosis and one which you may or may not see in your career. Pheochromocytoma is a rare neoplasm of the adrenal medullary chromaffin cells. When the tumor arises outside of the adrenal gland, it's termed a paraganglioma. There are a variety of forms. You can see it in a sporadic form where there's no family history. And this occurs in most commonly middle-aged adults, but you can see it at any age. There's a slight female predominance. Approximately 10% are bilateral and approximately 10% are malignant. Hereditary forms, you can see it in multiple endocrine neoplasia, types 2A and 2B. Occasionally you can see it in MEN1, but not commonly. In the hereditary forms, it's more commonly childhood in onset. It has a slight male predominance. And in the hereditary forms, it's very commonly bilateral. Approximately 70% in MEN2 are bilateral. You can also see it in other forms. For example, the von Hippel-Lindau syndrome. Recall that the von Hippel-Lindau syndrome is an inherited multisystem disorder caused by abnormal proliferation of blood vessels that are termed angiomas or hemangioblastomas. And these can occur in a variety of tissues and give rise to pathology. Really determining the symptoms and signs are determined by where these angiomas and hemangioblastomas arise. You can have cerebellar hemangioblastomas leading to cerebellar signs. As said, von Hippel-Lindau syndrome is associated with pheochromocytoma, also with renal cell carcinoma, as well as renal, hepatic, pancreatic, and epididymal cysts. Von Hippel-Lindau gene is a tumor suppressor gene, and a mutation in the von Hippel-Lindau gene is inherited in an autosomal dominant fashion. Another form associated with pheochromocytoma is the Sturge-Weber syndrome. This syndrome is characterized by hemangiomas of the fifth cranial nerve, the ophthalmic cranial nerve. You can also see cutaneous angiomas termed a port wine stain in Sturge-Weber syndrome. And as said, it's associated with pheochromocytoma. In terms of clinical features of pheo, the classic triad that med students recall are headache, diaphoresis, and palpitations. And these are periodic symptoms. You can also have this sensation of impending doom. Patients literally feel like they're going to die. Patients may simply present with refractory hypertension, and a workup for secondary causes of hypertension will reveal pheochromocytoma. Approximately 10% of pheochromocytomas, as mentioned, are malignant. An initial workup can show, you can do a 24-hour urine collection for metanephrines and catecholamines, and they will show elevated levels. You can also occasionally see hyperglycemia and occasionally frank diabetes in pheochromocytoma because of the insulin resistance that is caused by the excess catecholamines. Occasionally, I shouldn't say occasionally, actually fairly commonly in hospitalized patients, being in the hospital is a very stressful event, and more than likely the patient is very sick, and so the catecholamine levels are very high. So you will see difficult to control hypertension in the hospital, and sometimes that is difficult to differentiate between refractory hypertension or a pheochromocytoma. To make that distinction, and if the biochemical workup is a little indeterminate, you can do a clonidine suppression test. So clonidine is a sympatholytic. It's essentially acting inhibitor of sympathetic outflow. So if someone is anxious or in pain, or for whatever reason has a lot of sympathoadrenic drive, if in response to clonidine, their catecholamine levels, plasma catecholamine levels, should drop because it inhibits sympathetic outflow from the central nervous system. If you have an autonomously secreting tumor of the adrenal gland, it will not respond whatsoever to clonidine. So if someone has pheochromocytoma and you give them clonidine, there will be no significant change in plasma catecholamine levels. If it's just because they're in pain and they're anxious and their blood pressure is high and you give them clonidine, their catecholamine levels should drop. How do you treat? I should mention one other possible way that patients with pheochromocytoma can present. In response to a beta blocker, which of course normally lowers blood pressure, a patient with pheochromocytoma can have an increase in blood pressure, so a paradoxical increase. In fact, several years ago, I was doing endocrinology rotation, and I saw a 39 or 40-year-old woman come in with chest pain, and she went into the emergency room. Of course, they gave her a beta blocker and some nitrates while they were doing an EKG and some morphine and oxygen, and all the typical things that you would do for myocardial infarction. And they gave her a beta blocker, and her systolic blood pressure promptly went from about 150 or so to about 280 millimeters of mercury. So that was a clue that perhaps she had something rare like a pheochromocytoma, and in fact further workup showed that she did have a pheochromocytoma. In terms of treatment of pheochromocytoma, alpha blocking agents are first-line therapy. Beta blockers, I should say, with excess catecholamine secretion, catecholamines, epinephrine can bind to beta adrenergic receptors as well as alpha adrenergic receptors. If you block all of the beta adrenergic receptors with beta blockers, then you get unopposed alpha-mediated vasoconstriction, and that's why you get that paradoxical increase in blood pressure in response to beta blockers. And ultimately, the treatment for pheochromocytoma is a surgical excision. This pathology slide is showing a pheochromocytoma. There's areas of, you'll see areas of hemorrhage. It's enclosed in the cortex here, the capsule of the cortex, and the rest of the adrenal gland is shown below here. Another adrenal tumor is a neuroblastoma. And I said there was some hesitation because this can arise in a variety of locations. It doesn't have to arise in the adrenal gland. Neuroblastomas are a cancer of the sympathetic nervous system. It may arise in the sympathetic chain. It may arise in the adrenal medulla. If it does occur in the adrenal medulla, it can be large and bulky, and it can present with abdominal distension and abdominal pain. Neuroblastoma is actually the most common extracranial solid cancer in infancy, particularly in less than 1 year of age, but also I believe in childhood as well. Because of the excess catecholamine secretion, you can get hypertension. When you do a laboratory workup for a neuroblastoma, it's similar to pheochromocytoma in that you'll have increased urinary excretion of catecholamines and catecholamine metabolites. Now we're moving to multiple endocrine neoplasia. Multiple endocrine neoplasia has an autosomal dominant pattern of inheritance. It's a neoplasm, as its name implies. It's a neoplasm involving multiple endocrine organs. And there's two types that you should know about for boards. MEN1, you may recall, is the 3 Ps. So parathyroid, pancreas, and pituitary. In the parathyroid gland, parathyroid hyperplasia and adenomas can cause hyperparathyroidism. Parathyroid adenomas are the most common way that hyperparathyroidism presents in MEN1. Pancreatic tumors include gastrinoma and insulinoma, and gastrinoma is actually the most common pancreatic tumor, islet cell tumor, when seen in the context of MEN1. Pituitary tumors can range the whole gamut, but they actually mimic the normal spectrum of pituitary tumors, and in that prolactinomas are the most common. The MEN1 gene is located on chromosome 11, and it's a tumor suppressor gene. MEN2 is subclassified into MEN2A and 2B. MEN2A includes pheochromocytoma and the majority of these are bilateral, as mentioned before. Rather than hyperparathyroidism, you can see a medullary carcinoma of the thyroid, and this should really be removed prophylactically. And this is part of the reason taking a good history is so important. If someone presents with hyperparathyroidism, or actually if someone presents with a pheochromocytoma, you really have to ask about a family history of other endocrine disorders, of thyroid disorders, because you don't want to miss medullary carcinoma of the thyroid, which can be fatal. Parathyroid hyperplasia is seen as well, and this is caused by mutations in the RET proto-oncogene. Multiple endocrine neoplasia 2B is associated with pheochromocytoma, also medullary carcinoma of the thyroid, and neuromas or gangliomas, rather than parathyroid hyperplasia. This is also related to mutations in the RET proto-oncogene. This concludes our presentation of adrenal tumors.